Hi, welcome to our channel of IGNOU audiobooks, Indira Gandhi National Open University, School of Health Sciences, SOHS, Certificate Programs, Certificate in Newborn and Infant Nursing, CNIN, BNS 115 Nursing Care of Newborn and Infant, Block-1 Preventive and Promotional Aspects of Newborn, Unit-1 Importance of Newborn Care, 1.1 Introduction. Birth of healthy newborn is one of the finest gifts of nature. You know that when a baby is born, baby has to adapt from intrauterine life to extrauterine life. The newborn's survival is dependent on his ability to adapt to his extrauterine environment. This involves adaptations in cardiopulmonary circulation and other physiological adjustments to replace placental function and maintain homeostasis. Simultaneously, newborn has to make major adjustment in respiratory and circulatory system as well as in maintaining body temperature. These initial adaptations are crucial to his subsequent well-being and should be facilitated by trained and skilled nursing personnel. Basic needs of any newborn include breathing, warmth, cleanliness and feeding. All newborns require essential newborn care to minimize the risk of illness and maximize their growth and development. Essential care of the newborn will prevent many newborn emergencies, e.g., cleanliness at delivery reduces the risk of infection for the mother and baby. The umbilical cord may be the most common source of neonatal sepsis and also of neonatal tetanus, and good cord care could dramatically reduce the risk of this serious condition. Breastfeeding has the significant protective effect against infections. Early breastfeeding and the baby nursed close to the mother reduces the risk of hypothermia and as well as hypoglycemia. Newborn health is the foundation of child and adult health. A healthy start to life also depends on the health of the mother and the care that she and her baby receive before, at and after birth. Evidence-based intervention can save millions of lives of newborn in India in the next few years. Translating knowledge into action is the key to meeting the challenge and realizing the goal. This unit shall appraise you regarding significance of care of the newborn, which is primarily aimed at helping the newborn to adapt to the extrauterine environment. We shall also learn review meaning of various terms related to neonatology, health indices related to newborn, national health programs and policies related to newborn, epidemiological and physiological aspects of newborn. 1.2 Definition of terms. It is essential for nurses involved in the care of newborn to understand terms related to neonatology. The common definitions and terms are described below. Fetus. Fetus is a product of conception, irrespective of the duration of pregnancy, which is not completely expelled or extracted from his mother. Up to 8 weeks of gestation it is referred to as embryo. Live birth. Live birth is defined as complete expulsion or extraction from the mother, a product of conception, irrespective of duration of pregnancy, and which, after such separation, breathes or shows any other evidence of life such as beating of the heart, pulsation of umbilical cord. In 1970, WHO recommended that babies weighing less than 500 grams at birth should show signs of life for at least 1 hour before they are designated as live. Born. Perinatal period. Perinatal period extends from the 28th week of gestation, or more than 1000 g, to the 7th day of life. Neonatal period. Neonatal period extends from birth up to 28th day of life. Early neonatal period refers to first 7 days of life, while late neonatal period signifies period from 7 days to 28 completed days of life. Neonate. Infant from birth up to 28 days of life is called as neonate. Low birth weight. The internationally accepted definition of a low birth weight baby is one whose weight at birth is 2500 grams or less. WHO 1977. Further, subdivisions within this group include the very low birth VLBW, baby weighing 1001 to 1500 grams, and the extremely low birth weight ELBW, who weighs 1000 grams or less. Term infant. A term infant is born with a gestational age between 37 to 41 weeks. Preterm. A preterm infant is born before 37 completed weeks of gestation. Postterm. A post-term infant is born with a gestational age of 42 weeks or more. Appropriate for gestational age. AGA, a newborn whose birth weight lies between the 10th and 90th percentile is considered appropriate for gestational age. Large for gestational age. LGA, a newborn whose birth weight is greater than the 90th percentile is described as large for gestational age. Small for gestational age. SGA, a newborn whose birth weight is below the 10th percentile is described as small for gestational age. 1.3 Significance of newborn care. Newborn health is the foundation of child and adult health. A healthy start to life also depends on the health of the mother and the care that she and her baby receive before, at, and after birth. Evidence-based intervention can save millions of lives of newborn. During the period of postnatal transition, the newborn encounters various environmental stimuli, i.e., light, temperature, sound. Newborn breathing is stimulated and changes from fetal circulation to neonatal circulation. It undergoes alteration in metabolic process with activation of liver and gastrointestinal tract. For passage of meconium, the first 24 hours of life are critical as respiratory distress and circulatory failure can occur rapidly with little warning signals. Most newborns make the necessary biophysiological, psychosocial adjustment to extrauterine existence without undue difficulty. Their well-being depends on the nursing care they receive during these critical hours. Hence, it is essential that the newborn care is provided on the basis of careful assessment of biologic and behavioral responses and identifying problems based on the assessment findings. It includes planning and implementing appropriate nursing action and evaluating its effectiveness. 1.4 Health indices related to newborn and infant care. It is essential for nurses involved in the care of newborn to understand health indices related to newborn care. The health indices are discussed below. 1.4.1 Definitions and trends. Definitions. Crude birth rate. The crude birth rate is defined as the number of live births during a year per thousand estimated mid-year population, number of live births during the year upon mid-year population into 1,000. Fetal death. Death prior to the complete expulsion or extraction from mother A, product of conception, the death being indicated by absence of any signs of life. Infant mortality rate. An infant death is one occurring in the first year of life. It is defined as rate of infant deaths registered in a given year to the total number of live births registered in the same year, usually expressed as a rate per 1,000 live births. Number of infant deaths during the year upon number of live births. During the year into 1,000, infant mortality rate is taken as one of the best measures of nation's health. Stillbirth, the death of fetus weighing at least 500 grams, or when birth weight is unavailable. After 22 completed weeks of gestation or with a crown heel of 25 centimeters or more, before the complete expulsion or extraction from its mother. Perinatal death, the death of fetus weighing at least 500 grams, or when birth weight is unavailable. After 22 completed weeks of gestation or with a crown heel of 25 centimeters or more, or the death of an infant during the first week of life. Neonatal death, the death of a live-born infant during the period that commences at birth and ends 28 completed days after birth. Neonatal mortality rate, NMR, number of deaths among live births during the first 28 completed days of life per 1,000 live births. Early neonatal mortality rate, ENMR, number of newborn deaths less than 7 days of life expressed as per 1,000 live births in the reference year. Late neonatal mortality rate, LNMR, number of newborn deaths of 7 days to 28 completed days of life expressed as per 1,000 live births in the reference year. Post-neonatal mortality rate, PNMR, number of infant deaths of 29 days to less than 1 year of age expressed as per 1000 live births in the reference year, perinatal mortality rate, PMR number of deaths of fetuses weighing at least 500 g or when birth weight is unavailable after 22 completed weeks of gestation or with a crown heel length of 25 centimeters or more, plus the number of early neonatal deaths per 1000 total births, stillbirth rate, SBR number of stillbirths per 1000 births, live and still births during the reference year, trends in neonatal, infant and child mortality as seen in Table 1.1 show a slow but steady decline in infant mortality rate, IMR. The decline is a consistent 1. Under 5 mortality also shows a gradual decline over the period of years. There is a slow decline in early and late neonatal mortality rate, Table 1.1, Trend for Child Mortality Rates SRS data, 2010. Look at the screen. The figure 1.1 below shows consistent decline in U5 MR and IMR with slow decline in NMR. Fig. 1.1 Neonatal mortality, infant and under 5 mortality rate in India, SRS 2010. Policy makers identified goals in terms of infant, neonatal and under 5 times neonatal deaths occur mainly at home, times more than half of deaths of children who die in the first 5 years of life occur in the first month after birth, times 73.3% neonatal deaths occur in the first week of life, times 39.5% on the day 1, times 6.7% on day 2. Hence, it is very important that the focus of care should be on first day and the first week. The presence of skilled birth attendant, SBA, is very essential to reduce the mortality among neonates. 1.4.2 Causes of neonatal and perinatal mortality. Causes of child mortality in India are respiratory infections, mostly pneumonia, diarrhea, measles, malaria or malnutrition and often a combination of these illnesses, as per WHO 2012 estimates. The causes of child mortality in the age group 0 to 5 years in India, the above mentioned pie diagram shows that out of total, 55% of infant deaths occur during the newborn period. Most of these deaths take place due to birth, asphyxia, prematurity and infections. Some of the causes of neonatal deaths are attributable to birth trauma, low birth weight, intraventricular hemorrhage and necrotizing enterocolitis. Almost 8 million low birth weight (LBW) infants are born in India each year, an incidence of nearly 30% to 40% of the global burden, the highest of any country. 3/4 of neonatal deaths occur in LBW babies, who are at an 11 to 13 times higher risk of mortality during the neonatal period compared to normal birth weight babies. LBW babies continue to suffer higher morbidity and mortality beyond the neonatal period, and a growing body of evidence from the country suggests that full-term LBW babies are at a high risk of developing a variety of adult-onset diseases. Majority of LBW infants in India are full-term, with the prematurity rate varying from 11 to 14%. Over 80% of LBW babies weigh between 2,000 to 2,499 grams, and approximately 3% weigh less than 1,500 grams. Community-based studies show that most LBW babies can survive in home settings with simple, low-cost interventions delivered by community health workers. Neonatal infections, pneumonia, septicemia, meningitis, and diarrhea are the most common causes of mortality in neonates, accounting for almost half of deaths. Staphylococcus aureus, Klebsiella, and Escherichia coli are the three principal organisms of sepsis. The treatment of neonatal sepsis in home settings with oral clotrimazole and intramuscular injection gentamicin by village health workers has been shown to reduce sepsis-associated neonatal deaths by 76%. Sepsis-causing organisms in hospitals show a widespread resistance to commonly used antibiotics, asphyxia is the second most common cause of neonatal deaths. Up to 2 to 4% of babies suffer from significant asphyxia at birth in homes. Studies conducted in the country have shown that resuscitating asphyxiated neonates at birth using room air is as effective as using oxygen. In operational research settings, community-based health workers and traditional birth attendants have demonstrated the effective use of bag and mask ventilation for neonatal resuscitation of home-delivered babies. 1.5 Physiological aspects. The first 24 hours of life of newborn constitute a highly vulnerable time, during which neonate must make major physiologic adjustments to extrauterine life. In this section you will learn about various physiological features of neonates which make them susceptible to certain problems such as hypothermia, feeding problems with regurgitation, poor fat absorption, physiological jaundice, hypoglycemia, hemorrhagic diseases of newborns, fluid and electrolyte imbalance, susceptibility to infections, thermal adaptation. In newborn, temperature regulation mechanism is not completely developed. Neonate responds readily to alteration in environmental temperature. At birth, heat loss occurs due to evaporation, conduction, convection, and radiation. Larger surface area, decreased brown fat, thinner skin, blood vessels close to the skin surface results in heat loss. Newborns are susceptible to hypothermia and hyperthermia. As a nurse, you must know about the mechanism of heat loss, concept of warm chain. Signs and symptoms, prevention and management of hypothermia and hyperthermia in newborns in order to carry out appropriate interventions promptly and thus prevent complications. You will learn about thermal protection and kangaroo mother care in Unit 3 of Block-2. Gastrointestinal changes. The newborn's intestinal tract is proportionately longer than the adult's. Elastic tissue and musculature are not fully developed. Neurologic control is variable and inadequate. Most digestive enzymes are present except pancreatic amylase and lipase. Protein and carbohydrates are easily absorbed but fat absorption is poor. Imperfect control of the cardiac and pyloric sphincters causes mild regurgitation or vomiting. Irregularities in peristaltic motility slows gastric emptying. Increased peristalsis in the lower ileum result in 1 to 6 stools per day. These physiological aspects of neonates should be considered by neonatal nurses while providing feeding to neonates. You will learn about infant feeding in Block 2 Unit 4. Hepatic function. Hepatic function is limited because of lack of gastrointestinal tract activity and limited blood supply. This leads to increased ability to conjugate bilirubin and they are susceptible to physiological jaundice, decreased ability to regulate blood glucose concentration and thereby resulting in neonatal hypoglycemia. Deficient production of prothrombin and vitamin K thus predisposing neonates to hemorrhagic diseases. Neonatal nurses should understand these salient physiological aspects of newborn related to hepatic function to recognize neonatal jaundice, hypoglycemia and hemorrhagic disorders. You will understand about this in detail in Unit 3 of Block 3. Renal function. Low arterial blood pressure and increased renal vascular resistance lead to decreased ability to concentrate urine because of low tubular resorption rate and low levels of antidiuretic hormone, limited ability to maintain water balance and acid-base mechanism, slower excretion of electrolytes especially sodium and the hydrogen ions. Results in accumulation of these substances which predisposes the neonate to dehydration, acidosis and hyperkalemia. These physiological handicaps necessitate monitoring of fluid and electrolyte status in newborn and observe for any deviation to carry out appropriate intervention timely. You will learn in detail about assessment of fluid and electrolyte status and nurses' responsibilities in maintaining fluid and electrolyte balance in neonates in Block 3 Unit 2. Table 1.3 shows the various physiological handicaps and associated problems of newborn. Table 1.3 physiological handicaps and associated problems in the newborn. Look at the screen. 1.6 National Health Programs and Policies related to newborn care. Several initiatives have been undertaken by the Ministry of Health and Family Welfare, MOHFW, to reduce maternal and newborn mortality and morbidity. The provision of maternal and child health services in India dates back to pre-independence era as in 1880 with establishment of different fund committee and training schemes for midwives, doctors and other health workers in the field of maternal and child health. After independence, the state and central government worked hand in hand to provide the facilities by developing health programs for mothers and children. The various programs are as follows. Various child health programs have been implemented in India to improve health status of neonates. In 1977, Maternal and Child Health Program (MCH) became an integral part of the Family Welfare Program. In 1978, Diarrheal Disease Control Program was launched, and in 1990, Universal Immunization Program (UIP) was introduced to protect children including neonates and infants against vaccine-preventable diseases. Acute Respiratory Tract Infections (RE) Control Program was also started in 1990. All these programs were then merged into Child Survival and Safe Motherhood Program CSSM.1 Child Survival and Safe Motherhood CSSM. It is a package of services for improving the health status of women and children, reducing the maternal, infant and child mortality rates. It was started in August 1992 with the aim of times eliminating neonatal tetanus, times reduction of measles incidences, times eradicating poliomyelitis, times reducing the perinatal mortality, times reducing the infant mortality, times reducing the under 5 mortality. The program has two components: Safe Motherhood, which was initiated in states where infant and maternal mortality rates were high to ensure safe motherhood initiative, and maternal care, early identification and treatment of maternal complications, and family planning. Child Survival Program stresses on exclusive breastfeeding of the infants and aims at reducing the infant and child mortality and morbidity by immunization, control of vitamin A deficiency, control of acute respiratory infections and management of diarrhea. 2. Reproductive and Child Health Program RCH Family Welfare Program was reoriented and renamed as RCH Program in April 1996 to provide complete services to women and children in terms of better quality, coverage, effectiveness and access. It covers the services offered by CSSM and Family Welfare Program as well as looks into management of the reproductive infections and adolescent reproductive health RCH package of services for mothers, times registration of pregnancies, times to tetanus toxoid immunization doses during pregnancy, times 3 antenatal checkups including BP to rule out complications, times iron and folic acid tablets for preventing and treatment of anemia in pregnant women, times encourage safe and hygienic deliveries, times encouraging hospital deliveries, times referral of the obstetric emergencies, times 3 postnatal checkups after delivery, times motivation for family planning for children, times essential newborn care like keeping the baby warm, checking the baby's weight and giving the mother's first milk, times special care to LBW, premature babies, referral for infants with complications, times encouraging exclusive breastfeeding for first 6 months and weaning after 6 months, times administering BCG, DPT, polio and measles immunization as per the present schedule, times administer vitamin A to prevent blindness, times inform parents about OT and correct management of diarrhea, times educate about RE. Refer acute cases of RE to health centers, times treat anemia for eligible couples, times encourage contraceptive methods of family planning in eligible couples to prevent unwanted pregnancies, times educate women about safe services of medical termination of pregnancies, MTP, who desire abortions, other services, times find people suffering from reproductive tract infections and sexually transmitted diseases, since these led to infertility, affect the health of the deceased couples and children, and hence should be referred to health centers, times preparing the adolescents for the future parenthood by counseling about times reducing TFR to 2.1, various programs and policies launched under NRHM R1, reproductive, maternal, newborn, child and adolescent health, RMNCHA, a strategic approach launched under NRHM, RMNCHA aims to address the major causes of mortality among women and children, as well as the delays in accessing and utilizing healthcare services. It proposes the spread of health care across the various life stages, thus generating a continuum of care. The goals of RMNCHA are times reduction of infant mortality rate (IMR) to 25 per 1,000 live births by 2017, reduction in maternal mortality rate (MMR) to 100 per 100,000 live births by 2017, times reduction in total fertility rate (TFR) to 2.1 by 2017. The targets of RMNCHA are times increase facilities equipped for perinatal care by 100%, times increase proportion of all births in government and accredited private institutions at annual rate of 5.6% from the baseline of 61%, SRS 2010, times increase proportion of pregnant women receiving antenatal care at annual rate of 6% from the baseline of 53%, CES 2009, times increase proportion of mothers and newborns receiving postnatal care at annual rate of 7.5% from the baseline of 45%, CES 2009, times increase proportion of deliveries conducted by skilled birth attendants at annual rate of 2% from the baseline of 76%, CES 2009, times increase exclusive breastfeeding rates at annual rate of 9.6% from the baseline of 36%, CES 2009, times reduce prevalence of under 5 children who are underweight at annual rate of 5.5% from the baseline of 45%, NFHS 3, times increase coverage of 3 doses of combined diphtheria tetanus pertussis, DTP 3, 12 to 23 months, at annual rate of 3.5% from the baseline of 7%. CES 2009, times increase ORS use in under 5 children with diarrhea at annual rate of 7.2% from the baseline of 43%. CES 2009, times reduce unmet need for family planning methods among eligible couples, married and unmarried, at annual rate of 8.8% from the baseline of 21%, DLHS 3, times increase met need for modern family planning methods among eligible couples at annual rate of 4.5% from the baseline of 47%, DLHS 3, times reduce anemia in adolescent girls and boys 15 to 19 years at annual rate of 6% from the baseline of 56% and 30%, respectively. NFHS 3, times decrease the proportion of total fertility contributed by adolescents 15-19 years at annual rate of 3.8% per year from the baseline of 16%. NFHS 3, times raise child sex ratio in the 0 to 6 years age group at annual rate of 0.6% per year from the baseline of 914. Census 2011, the healthcare facilities under RMNCHA are provided according to various life stages as 1. Adolescence, times adolescent nutrition, iron and folic acid supplementation, times facility-based adolescent reproductive and sexual health services. Adolescent health clinics, times information and counseling on adolescent sexual reproductive health and other health issues, menstrual hygiene, times preventive health checkups. 2. Pregnancy and childbirth, times delivery of antenatal care package and tracking of high-risk pregnancies, times skilled obstetric care, times immediate essential newborn care and resuscitation, times emergency obstetric and newborn care, times postpartum care for mother and newborn, times postpartum IUCD and sterilization, times implementation of Preconception and Prenatal Diagnostic Techniques PCPNDT Act 3, Newborn and Child Care, times home-based care and referral, times facility-based care, times child nutrition and essential micronutrient supplementation, times integrated management of neonatal and childhood illnesses or MNCI, times immunization, times child health screening and early intervention services, Rashtriya Bal Swasthya Karyakram 4, throughout reproductive years, times doorstep distribution of contraceptives, times promotion of spacing methods like interval IUCD, times sterilization services, times comprehensive abortion care, times management of sexually transmitted diseases, STD, and reproductive tract infections, RTI. The approach also focuses on provision of care to the tribal and urban, disadvantaged poor for equality in health care services with strengthening of the available resources to ensure the availability of the health care facilities. 2. Janani Suraksha Yojana, JSY. It is a safe motherhood intervention under the National Rural Health Mission, NRHM. It is being implemented with the objective of reducing maternal and neonatal mortality by promoting institutional delivery among poor, pregnant women. The scheme is under implementation in all states and union territories, UTs, with a special focus on low-performing states, LPS. It was launched in April 2005 by modifying the National Maternity Benefit Scheme, NMBS. The NMBS came into effect in August 1995 as one of the components of the National Social Assistance Program, NSAP. The NMBS provides financial assistance of 500 rupees per birth up to 2 live births to the pregnant women who have attained 19 years of age and belong to below poverty line, BPL, households. When JSY was launched, the financial assistance of 500 rupees was made available uniformly throughout the country to BPL pregnant women under NMBS, was replaced by graded scale of assistance based on the categorization of states as well as whether beneficiary was from rural-urban area. States were classified into low-performing states and high-performing states on the basis of institutional delivery rate, i.e. states having institutional delivery 25% or less were termed as low-performing states, LPS, and those which have institutional delivery rate more than 25% were classified as high-performing states, HPS. 3. Janani Shishu Suraksha Karyakram, JSSK. Government of India has launched Janani Shishu Suraksha Karyakram, JSSK, on 1st June 2011. The following are the free entitlements for pregnant women: times free and cashless delivery, times free C-section, times free drugs and consumables, times free diagnostics, times free diet during stay in the health institutions, times free provision of blood, times exemption from user charges, times free transport from home to health institutions, times free transport between facilities in case of referral, times free drop back from institutions to home after 48 hours stay. The following are the free entitlements for sick newborns till 30 days after birth, times free treatment, times free drugs and consumables, times free diagnostics, times free provision of blood, times exemption from user charges, times free transport from home to health institutions, times free transport between facilities in case of referral, times free drop back from institutions to home. 4. Facility-based newborn and child care. Neonatal mortality is one of the major contributors, 2/3, to the infant mortality. To address the issues of neonatal and early neonatal mortality, facility-based newborn care services at health facilities have been emphasized. Setting up of facilities for care of sick newborns such as special newborn care units, SNCUs, newborn stabilization units, NBSUs, and newborn baby corners, NBCCs, at different levels is a thrust area under NRHM. Special newborn care units, SNCU. Times states have been asked to set up at least one SNCU in each district. SNCU is 12 to 20 bedded unit and requires 4 trained doctors and 10 to 12 nurses for round-the-clock services. Newborn stabilization units, NBSUs. Times NBSUs are established at community health centers FIUs. These are 4 bedded units with trained doctors and nurses for stabilization of sick newborns, newborn care corners, NBCCs. Times these are 1 bedded facility attached to the labor room and operation theatre (OT) for provision of essential newborn care. NBCC at each facility where deliveries are taking place should be established. 5. Integrated management of neonatal childhood illnesses, IMNCI. It includes pre-service and in-service training of providers, improving health systems, e.g. facility upgradation, availability of logistics, referral systems, community and family-level care. 6. Facility-based integrated management of neonatal and childhood illness, FMNCI. FMNCI is the integration of the facility-based care package with the MNCI package to empower the health personnel with the skills to manage newborn and childhood illness at the community level as well as at the facility. Facility-based MNCI focuses on providing appropriate skills for inpatient management of major causes of neonatal and childhood mortality such as asphyxia, sepsis, low birth weight, and pneumonia, diarrhea, malaria, meningitis, severe malnutrition in children. This training is being imparted to medical officers, staff nurses, and ANMs at CHC FIUs and 24/7 PHCs where deliveries are taking place. The training is for 11 days. 7. Home-based newborn care, HBNC. A new scheme has been launched to incentivize ASHA for providing home-based newborn care. ASHA will make visits to all newborns according to specified schedule up to 42 days of life. The proposed incentive is 50 rupees per home visit of around 1 hour duration, amounting to a total of 250 rupees for 5 visits. This would be paid at one time after 45 days of delivery, subject to the following: times recording of weight of the newborn in MCP card, times ensuring BCG, first dose of OPV and DPT vaccination, times both the mother and the newborn are safe till 42 days of the delivery, and times registration of birth has been done. A comprehensive home-based newborn care operational guideline 2011 has been developed, published and disseminated in 2011 by Child Health Division, MOHFW, GOI to provide framework and guidance to enable a coherent home-based newborn care strategy and act a reference tool for the states to plan necessary interventions. Care of the newborn baby and mother by ASHA through regular home visits on 1 cent, 3 RD, 7th, 14th, 21 cent, 28th, and 42nd day for home deliveries. 3 RD, 7th, 14th, 21st, 28th, and 42nd day for institutional deliveries. 8. Navjat Shishu Suraksha Karyakram, NSSK. NSSK, a program aimed to train health personnel in basic newborn care and resuscitation, has been launched to address care at birth issues, i.e., prevention of hypothermia, prevention of infection, early initiation of breast feeding, and basic newborn resuscitation. Newborn care and resuscitation is an important starting point for any neonatal program and is required to ensure the best possible start in life. The objective of this new initiative is to have a trained health personnel in basic newborn care and resuscitation at every delivery point. The course has been developed for medical officers, nurses and ANMs who are posted at health centers, CHCs FIUs 24/7, PHCs and small hospitals, not referral hospitals, and are responsible for conducting deliveries and managing newborn babies. The training is for 2 days and is expected to reduce neonatal mortality significantly in the country. 1.7 Roles and responsibilities of nurse in perinatal and neonatal care. Neonatal nursing, being the specialized branch of nursing, demands high standard of nursing care in taking care of newborns. Neonatal care unit places a great demand on nurses involved because emergency can happen at any time, decisions and actions have to be quick and precise. A neonatal nurse is expected to have a high sense of responsibility, devotion to work, keen sense of observation, alertness, and readiness to take quick decision. Neonatal nurses who are able to carry out nursing care with knowledge, skill, and confidence contribute significantly to the neonatal outcome. The following are the roles and responsibilities of nurse in newborn care. Times nurses play an important role in perinatal and neonatal care at healthcare facilities, from being skilled attendance professionals at birth to managing sick neonates, from counseling mothers about breastfeeding to advising home care of high-risk neonates, from implementing kangaroo mother care to stabilizing sick neonates. Times they monitor neonates during intrapartum, postpartum and neonatal period. Times neonatal nurses perform various procedures including maintenance of equipments in nursery. Times the nurse's ability to observe, report and record the symptoms of newborn, such as color, edema, presence of scleroderma, rashes, respiratory rate, abdominal distension, apparent anomalies, cry activity, tremors and bulging, fontanelle etc. helps to reduce neonatal mortality and morbidity. Times nurses working in neonatal care unit because of their round-the-clock contact with high-risk baby are in a good position to detect early signs and symptoms of distress. Early diagnosis and treatment may shorten the course of disease and improve the survival rate. Times neonatal nurse is responsible for assessing, documenting, planning, implementing and evaluating care. Nursing assessment allows the nursing personnel to organize patient data into a standard nomenclature that can be used as a guide for decision-making. 1.8 Summary: skilled care at and around birth is imperative for saving newborn lives. Neonatal mortality rate accounts for about 40% of under 5 mortality. Further reduction in under 5 mortality would be depending on the attention given to neonatal health and survival. Almost one-third of newborns weigh less than 2,500 grams. This poses a special challenge for their survival and development. The reasons for high neonatal mortality are not only medical but also have social and economic dimensions. Due attention to health system strengthening, attention to family and community practices and coordinated initiatives across several sectors to meet local specific imperatives are therefore needed for accelerating progress towards meeting the essential newborn care. India is the world's largest democracy, largest country in Southeast Asia, the second most populous country in the world and contributes to around 20% of global births. Focus on young infants is important since a significant proportion of child mortality is centered in the first few months of life. High incidence of neonatal mortality rate and associated problems due to physiological handicaps poses a challenge for health personnel to provide competent nursing care during birth process and neonatal period, which are imperative for saving newborn lives. In this unit, significance of nursing care in early identification of complication and prompt interventions and improving neonatal outcome is highlighted. Thank you. Subscribe to our channel for more updates and we will see you with the next chapter.